Hello and welcome to the Multiple Sclerosis Association of America's live webinar, What You Need to Know About COVID-19 and MS, Program 3. I'm your host, Peter Demiri, Vice President of Programs and Services, and glad to be here on tonight's program. This third webinar is part of an ongoing series designed to help you stay as informed and updated as possible on the constantly changing news around COVID-19 and how to best manage your MS. On behalf of MSAA and our presenters, we greatly appreciate the opportunity to be back here once again and to continue providing you with timely and urgently needed information. Also, please know that we continue to send our very best wishes to the entire MS community and hope you and your family stay safe and healthy in these uncertain times. MSAA is extremely honored to welcome back our two MS expert advisors who once again educate and update us about the coronavirus pandemic and its impact on MS, and answer your questions during our expanded Q&A session at the end of the program. At this time, I would like to introduce our special guest presenters, Dr. Barry Hendin and Dr. Carrie Hersh. Dr. Barry Hendin is MSAA's Chief Medical Officer and a practicing neurologist at Phoenix Neurological Associates. He is also the Director of the Multiple Sclerosis Clinic at Banner University Medical Center and Clinical Professor of Neurology at the University of Arizona Medical School. Dr. Carrie Hersh is the Chair of MSAA's Healthcare Advisory Council. She is a practicing neurologist and Assistant Professor of Neurology for the Cleveland Clinic Lou Reveau Center for Brain Health in Las Vegas, Nevada. Dr. Hendin and Dr. Hersh, thank you both so much for being here again tonight and continuing with our ongoing series on this very important issue.
Peter, I also want to tell you how happy I am, and I'm sure Dr. Hersh to join again with you and people over the telephone who have MS and are curious about a very current issue, and that is COVID-19 and the MS community. So I'm thrilled to be back again for now program number 3 and what we hope will be a continuing exploration of this subject.
Great, thank you so much. Well, before we begin, I want to provide a few updates, starting off by saying that our last COVID-19 webinar was on April 13th and is archived for those who want to watch it on our website. Also, tonight's program will be archived as well, and our next webinar in this series, as Dr. Hendon mentioned, will be on Monday, May 11th at 8 p.m. Eastern. And once again, the dynamic duo of Dr. Hendon and Dr. Hersh will be back to provide us with the latest updates and their very helpful insights. Registration on the May 11th webinar will be posted soon to our website at mymsaa.org/coronavirus. I also want to thank our funders, Bristol Myers Squibb, EMD Serono, and Genentech for making this webinar series possible. And also just adding another note of an update, we are currently working on trying to get a presenter for our next webinar that we would like to explore on COVID-19 and its impact on the African American community. So we are working to get that information secured, and then we will post that on our website as soon as possible. As you may know, MSAA is a national nonprofit organization dedicated to improving lives today for the MS community. In fact, this year marks our 50th anniversary as an MS organization. Listed here are just some of our many free programs available to people living with MS across the country, along with our ongoing updated information on COVID-19. Also, during this time, we have extended our helpline hours to 8 p.m. Eastern between Monday and Friday. I encourage everyone to visit our website at mymsaa.org or call us at 1-800-532-7667 to learn more. And lastly, as mentioned, we are recording and archiving this webinar and will work to post it to our website very soon. Also, we have expanded the Q&A session to help address as many questions as we can. During the program, you will need to type your questions into the chat box that you see on the screen. I will ask your questions to the presenters at the end once the Q&A session starts. When typing your questions, please try to make them as general as possible so they apply to the larger MS community. Also, if you are experiencing any technical issues with the webinar, please type those concerns into the chat box as well. So with all of that now covered, I am honored to once again introduce Dr. Barry Hendin, who will start the program.
Thank you very much, Peter. I suspect that some of you listening have heard Dr. Hersh and I in the previous two sessions, but that for many people this is the first visit to us, and so it may be worthwhile going over some of the common ground. What is the coronavirus? What is COVID-19? And what does it mean to the general community and then to the MS community? So I think in the most elemental level, this COVID-19 is a potentially serious inflammatory disorder that targets the respiratory system. The fact that it targets the respiratory system doesn't mean that it doesn't secondarily involve other parts of the body, which it may. It's part of a family of coronaviruses that in other people may be mild, such as a common cold, but this is a novel mutation of that virus. For those who haven't figured it out already, COVID-19 comes from the name corona, C-O, virus, V-I, disease, 2019. So COVID-19 is coronavirus disease, 2019, a disease caused by the coronavirus. It says here in the most elementary way, the initial symptoms are most commonly fever, persistent cough, shortness of breath. But that isn't the exclusive presentation. There are people who present with loss of sense of smell and taste. There are people who present with gastrointestinal illness, diarrhea, or some kind of abdominal discomfort. So we should be aware that though the most common is fever, cough, shortness of breath, that by no means is the exclusive. The next bullet point really is from the CDC, and it tells us what all of us should be doing. This is in a changing discussion, and Dr. Hersh and I are used to the fact that we're dealing with a new disorder, a new disease, and that much of what we're talking about has changed over the past couple of months and will be changing over the months ahead. What isn't changing is common sense, and that is people who have cough or sneeze should cover their mouth and nose, probably by sneezing into their sleeve, not their hands. Avoid touching their mouth and nose and eyes because that's a way to transmit the virus. Wash your hands frequently, clean surfaces frequently. This virus is a very contagious virus. If it were not so contagious and not so potentially serious, we wouldn't be having this discussion. But the thing that has brought it to a national level of concern is it's highly contagious and depending upon the individual, may be catastrophic. Most people don't have a serious or a debilitating illness, but some can, including fatality. So if a person thinks they might have a coronavirus and COVID-19, what should they do? They should try to keep themselves at home if they're mildly ill and don't have what seems to be life-threatening symptoms, particularly shortness of breath or difficulty getting oxygenation. And they should try to basically shelter in place. We say they should be contacting their clinician, but we know that it's harder to contact your clinician right now. The usual idea that you run into urgent care or run in to see your physician really has changed during COVID-19. But again, common sense. So if you do have symptoms that you think might be COVID-19 and they're mild, it's now a bit easier to get tested. One should try to do that. And then use common sense. Hydrate, get sleep, continue to the ability that you're able to get some fresh air and exercise. And those are the bits of sort of common sense. Let's see if I can advance this. Oops. Let's see.
You want me to advance it for you, Dr. Hendin?
I think I may have done it. Success. So I'm going to talk about bullet point 2 before bullet point 1. The slide is entitled Special Considerations for Individuals with MS. So if you drop down to bullet point 2, what it says is that having MS doesn't necessarily put you at greater risk for COVID-19 than anybody else around you. But that doesn't apply to everybody with MS. And certainly if you have MS with a debilitating course and have difficulty with breathing or difficulty with swallowing, then your risk has gone up because of those increased difficulties. By and large, we tell people that having MS does not create a significant increase in risk of getting COVID-19. We also say that we provide medications for people with MS, and our experience so far is that the MS population, when we've looked at the registries, do not look like they are having at this time a worse outcome than the general population. It's other comorbidities that really do seem to make the difference in outcomes. So first and foremost, age. People over 60 may have a higher instance of risk and fatal outcome. Over age 70, twice that. Over age 80, 3 times that. So age in and of itself is a very important factor in outcome. And then if you add comorbidities, it really does change the outcome further. What do I mean by comorbidities? Things like chronic heart diseases, chronic lung diseases, uncontrolled asthma, uncontrolled diabetes, obesity, smoking. These are things, some of which we should be paying particular attention to now because they make the difference. You can't keep from getting older. That comes with the territory, and we all want to be able to get older. But we should be able to watch over our blood pressures and pay attention to that, watch over our weight, exercise, watch over our asthma, lung diseases, make sure that our diabetes is controlled. So I want to draw attention to the fact that MS does not increase risk in and of itself, but that comorbidities become very important. And that some of those comorbidities are things that we should have been addressing a year ago and a month ago and should be addressing even more seriously now, including smoking, which carries increasing risk for COVID. The third bullet point says no consistent guidelines for managing disease-modifying therapies during COVID-19. And that what we're saying really is that these are discussions that we hope that each of you will be having with your clinicians. There are opinions out of Italy. There are opinions and guidelines out of England. There are opinions and guidelines out of the U.S. They have similar but not the same recommendations. So there are inconsistencies, but what everybody agrees is you don't stop your disease-modifying therapy or change your disease-modifying therapy without careful discussion with your clinical provider, with your clinician. Stopping some of the agents, in fact, carries an increased risk that we call rebound. So if you said, are there mixed opinions about which of the agents are safest and which of the agents may carry more risk? Yes. There are some variations of opinion. We're delighted that so far the MS population appears to be doing about as well as the general medical community that gets COVID-19. Do not stop your medicine. Do not change your medicine without the discussion with your clinician. Those are the comments I wanted to make, and I'd like to turn this over to Dr. Hersh. Carrie?
Thank you so much, Dr. Hendin. And before I start delving into the PowerPoint slides, I wanted to also say thank you to the MSAA for all of their continued efforts in making sure that our MS community consistently comes first, and their amount of dedication to our MS patients and caregivers, during the uncertain times that we have with COVID-19 is remarkable. And I just want to say thank you to the MSAA, and also thank you to Dr. Hendin. It has been such a pleasure to work with him during these MSAA webinars that we've been holding over the past month to 6 weeks. And I look forward to continuing to provide some robust information as we continue to move forward. So with that, I will go ahead and I'll provide some more specific information as it relates to individual disease-modifying therapies. In the MS community, there have been a lot of questions and queries in terms of disease-modifying therapy management. Should folks continue their DMTs? Should certain DMTs be suspended or held while there is a pandemic going around? And as Dr. Hendin had mentioned during the last slide, generally speaking, it is not recommended that folks stop their disease-modifying therapy or delay their disease-modifying therapy unless there is a specific indication to do so from their MS healthcare provider. And the reason for that is because MS, as we understand, is a chronic, long-term clinical diagnosis that can not only result in relapses and new MRI lesions, but certainly have a long-term implication in terms of how folks do in the long term. And there can certainly be some significant consequences to stopping disease-modifying therapies, and there being some, unprecedented relapses in MRI disease activity that could certainly occur if these DMTs are held. And then for specific disease-modifying therapies, which I'll go into, certainly this can result in even more significant and disabling and potentially irreversibly disabling relapses if they are held or suspended without a MS healthcare provider being able to transition them to another disease-modifying therapy. So all of these things really need to be taken on an individualized basis. And, for the most part, the recommendations that we have on the slide here that I'll go through point by point are more generalized blanket statements, but for individual care and folks who have different comorbidities, as Dr. Hendin had mentioned, that may predict an increased risk of either susceptibility to the virus or severity of the disease, or are in locations where they're unable to self-isolate. Those could potentially be even more concerning risk factors than the actual disease-modifying therapy itself. So everything really needs to be taken into account and individually stratified. So overall, the risks and benefits of therapy really do need to be discussed with the MS healthcare provider. And across the MS scientific community, we feel, based on best clinical practice, speculation, and expert opinion, that low-risk therapies include the self-injectable treatments, such as the gluteramine acetates and interferon beta therapies, teriflunomide, natalizumab, and fumarates, with the additional recommendation that with the fumarates, it really does depend on blood cell counts and whether or not individuals have blood cell counts, white blood cell counts, that fall within the normal range, or whether or not they are low. And folks who are on fumarates who have low absolute lymphocyte counts may have some additional risk factors compared to folks who are falling within normal ranges. Fortunately, the majority of folks who are treated with the fumarates do not tend to see a problem with low absolute lymphocyte counts, but every now and then we do see this as a potential adverse effect, and we may even see this in older populations a little bit more frequently. Intermediate risk therapies include the S1P modulators, fingolimod and siponimod, the monoclonal B-cell depleting therapies, ocrelizumab and rituximab, and cladribine. However, the risks and benefits, as I had mentioned before, really need to be weighed on a more individualized basis. And there have been some speculations whether or not folks who are treated with infusion therapy, such as ocrelizumab and rituximab, should have their treatment either suspended or delayed. And again, this really needs to be on an individualized basis. Are there other potential risk factors that are involved, either inherent comorbidities in the person himself or herself? So are they over the age of 60? Do they have uncontrolled diabetes? Do they have other chronic health and lung diseases that put them at risk? Are they permanently disabled, where they may have trouble with swallowing or clearing secretion? So if they ended up becoming susceptible to the virus, would they have an overall worse disease course, not because of the disease-modifying therapy itself, but because of their level of disability? And again, we also have to keep in consideration that, COVID-19 is not going away anytime soon, as what has been discussed with other leading experts. And the question is, how long can we really delay someone's treatment? What is considered appropriate? So again, this really does need to be discussed with the healthcare provider on an individualized basis. Another point that I want to make is, therapies including natalizumab and the S1P modulators, fingolimod and siponimod, there are significant risks of what we call rebound disease. So after these treatments are withdrawn or they're stopped suddenly, and there isn't another disease-modifying therapy that someone can transition onto, there is a significant risk of a severe clinical relapse that might actually incur more disability compared to when the person started those treatments in the first place. So, again, there has to be quite a bit of caution when someone is considering either changing their disease-modifying therapy or suspending treatment. And again, I stress that this really needs to be done with the assistance of an MS healthcare provider. Higher risk DMTs include alemtuzumab and hematopoietic stem cell treatment. Again, because of the amount of immunosuppression that is involved, and with HSCT chemotherapeutic management that needs to be completed before stem cell therapy is actually performed. So specifically in these patient populations, continuing therapy or starting therapy really need to be weighed individually. Right now, as I had mentioned, the points that we have on the slide currently are based on expert opinion and are speculative based on their mechanism of action and how we know they impact the immune system, whether or not they modulate or change the immune system, or whether or not they suppress the immune system. And not only whether or not they suppress the immune system, but what parts of the immune system they actually suppress, and how long-term are those effects, meaning how long is the immune system suppressed for if a patient is exposed to that therapy. So there are a lot of questions that have been raised, and we are doing a lot of work in the MS community to try to gather information in as much of a standardized fashion as possible, so that way we can be able to provide more evidence-based guidelines in caring for our patients. So there have been a lot of strong efforts internationally in order to develop these registries where individual data points are being collected and patient health questionnaires are going out to folks who actually develop the virus. So that way we can better understand how folks do in the MS community if they do develop the infection. What are their outcomes? How does that relate to the disease-modifying therapies they're treated with and other comorbidities that Dr. Hendin has talked about? So there is one leading effort that is a collaboration between the National MS Society and the Consortium of MS Centers called COVID-MS, which is a North American registry collecting a lot of really robust data on these patients across the United States, Canada, and I believe Mexico is also included to include North America. They have a website that is available to all individuals where healthcare providers are actually able to insert information, but there are some preliminary data that are available to the public. Currently, there are 112 patients with MS who have been included in this registry. And it appears that 91.4% of those who have tested positive for COVID-19 have either recovered or are currently recovering. So as Dr. Hendin had mentioned previously, it does not appear that MS alone is increasing the susceptibility to transmission nor the severity of the disease, but it really is these other risk factors that are playing a more important role. And there are other individual sites that are developing registries. I know the Cleveland Clinic has developed a very large registry with over 22,000 individuals who are currently being evaluated. And this is across other centers as well. And hopefully we'll be able to have some more finalized data in the weeks and months ahead. And we'll hopefully be able to report some of that information in the future. So what can folks do in the meantime when it comes to trying to stay healthy during all of this? This is an uncertain time, a very stressful time for folks around the world. And the good part about this is that the messaging that the MSAA and the MS community at large have been encouraging for quite some time is really no different than what we are encouraging now. And this isn't just for the MS population. This really is for everybody around the world. And these measures are how to stay physically and emotionally well. There are recommendations to make sure that you are getting plenty of good, adequate sleep, trying to remain physically active to the best of your ability. I know that there have been a lot of different virtual exercise platforms that have come onto the internet. In terms of going outside, I know that has been a very common question, whether or not it's okay for people to go outside. Yes, it is okay to go outside. Maintaining social distancing is certainly highly recommended. So that's at least 6 feet away from another individual. If that cannot be done, and I know that there are, certain areas of the country that really are mandating wearing a face covering if you're outside at all, that is something that would also be recommended as well. Managing stress is certainly a huge part of living well. And, it's a very difficult time for a lot of people. How can people manage stress? Well, trying to remain socially engaged with people. So social distancing does not equal social disengagement. So fortunately, we live in an environment where we have FaceTime and we have Zoom, and we have all of these different virtual platforms that are available so that we can remain connected with our loved ones. And certainly this can be a part of stress management simply by remaining connected to your friends and family. If folks do need something that is a little bit more comprehensive, there are certainly other strategies like meditation, self-reflection, guided imagery, deep breathing techniques, and mindfulness. And, I certainly encourage you to reach out to your MS healthcare providers if there are social workers on site or psychologists or health psychologists available in order to provide some more information on some of these platforms. A lot of them are going virtual and readily available to the public. Other things to stay well: drinking plenty of fluids and eating nutritious food. So again, this doesn't go beyond what we would recommend to the general public, not just folks with MS, but for everybody, to make sure that folks are remaining well hydrated and eating healthfully. So I would say that, these are certainly measures that folks can perform on a daily basis. It gives a sense of control back. And it has been shown that not only can this be fruitful during, these are uncertain times in relationship to COVID-19, but certainly for long-term MS care as well. So with that being said, I will go ahead and ask Peter to assist us with our question and answer session.
Great. Thanks, Dr. Hersh, and thank you as well, Dr. Hendin. Excellent presentation as from before as well. And we are getting a ton of questions, so I'm glad we have an engaged audience. One question that came in earlier in the program is it safe to do MRIs while COVID-19 is still very strong?
So I'll begin with that, and I'm also curious as to Dr. Hersh's thoughts. But we do MRI scans that are both sometimes urgent and sometimes routine. I think most of us feel that routine testing, be that the routine blood draws and routine MRIs, can be postponed in some cases or used with a little bit more conservative approach. Some of the blood tests we get really are very important. I think, for example, understanding lymphocyte counts for people on lymphocyte depleting agents, or getting JC virus testing for people who are on natalizumab. So some blood tests I've actually thought were important as scheduled. But this is a time when I ask myself questions about each of the tests I'm doing and ask myself, am I requiring a person to go into a medicalized atmosphere that really does create a risk for them greater than would have been the case a year ago? And on each occasion, I have to think about the fact that the risk-benefit ratio of getting the test has now changed. So the answer is I am still getting MRIs. I am still getting blood work, but I'm thinking more carefully about whether or not each of them is necessary, and I would recommend that discussion be between you and your clinician to find out whether this is a routine test, therefore something that can be postponed, or something that is, in fact, more urgent and should be done as scheduled.
Yes, I absolutely agree. I have nothing more to add to that. I'm doing the same thing in my practice.
Okay, very good. Next question. If on an immune modulator, are we more protected against COVID-19?
So I can go ahead and I can start this conversation off. So there have been some studies that have kicked off looking at some various antiviral medications and some of our anti-inflammatory therapies, including some of the disease-modifying therapies that we use for MS. Some of those have been interferon, fingolimod. I believe that there has also been some studies looking into teriflunomide as well. Currently, there are no firm data to show that there are certainly clinically meaningful beneficial outcomes. We certainly don't have that data yet. I would also like to add that the dosing that is required for treatment of COVID-19 with these disease-modifying therapies, specifically with interferon beta, would have to be at a much larger dose than what is currently being used as an anti-inflammatory agent for MS. So we really do have to, take these data in stride.
So, Carrie, I agree entirely. I was going to say there are occasions when I find myself quoting Bob Dylan, and the questions about how we are using our agents in MS really falls into that category. In the song, The Times Are Changing, there is a line that goes, "Keep your eyes wide, the chance won't come again, and don't speak too soon, for the wheel's still in spin. And there's no telling who that it's naming, for the loser now will be later to win." What that tends to say for me is we're only 5 months into this pandemic. We are still really trying to understand not just the risks as they relate to MS, but the risks as they relate to each of our medications. And in many cases, we're hearing, just as Dr. Hersh said, pros and cons. We know that some of our agents are immunomodulators and not immunosuppressants at all. With respect to the immunosuppressant agents, they have different mechanisms. And the question is whether they could create increased risk, perhaps, or benefit. We know that the greatest risk for mortality in COVID-19 appears to be the cytokine storm that causes a really abrupt and severe inflammation of the lungs that's autoimmune, or that I should say, that is an immune-mediated problem, not autoimmune so much as immune. It's an immune avalanche. So in some cases, you might say, well, then wouldn't it be beneficial to have something which would quiet the inflammation, quiet the immune system? What I'm really trying to say with all of this is it's complex. In the midst of the complexity, what Dr. Hersh has already said, and I would add, is we're still learning. That's the reason for the registry that Dr. Hersh mentioned. The registry right now gives us fairly broad detail about how people are doing, but we're going to get more granular. How do they do on each of the agents that we're using? Are the outcomes different at all? We don't know that. So keep your eyes wide. We are still learning. Don't think we know the answers completely. In the meantime, Dr. Hersh and I treat MS, and that is we watch to make sure that people get the medications they really need.
Well, thank you for that, and thanks for the Bob Dylan quote. I happen to like him as well, so that's awesome. There are actually quite a few questions around a potential vaccine, and certainly we've heard that in the news, and certainly we all wish for that. So I guess some of the questions are around whether it would be live or not, or whether it would be okay for people with MS to take it or not, and whether any DMTs would interfere with that or not.
So I'll begin, and I really am very interested, Carrie, in your thoughts as well. The answer is that people are really working on trying to find a vaccine. There are estimates in terms of how long it may be before we see that vaccine. that range from 6 months to 18 months. I just saw something across the news this afternoon that people in Oxford, in England, are rapidly going into trial with a vaccine against the coronavirus that they think may work on this unique mutation. Having said that we will at some point have a vaccine. I think it will be a non-live vaccine, but we'll have to wait to see the actuality, which would mean that people would be able to take that who have MS. But if they are on certain types of lymphocyte depleting agents, it may be that are permanently used, it may be that their response to the vaccination will be limited. So it's a time when we think about our agents. Will some of our agents reduce the power of a vaccine? Yes. Will shorter-term immunosuppression from which you can recover, or the use of immunomodulating agents interfere with vaccination? The answer is less likely. So I think it's still a matter of question, but it makes us look at each of the agents again and say, do all the agents behave the same? Certainly not. Will some interfere with vaccination? Probably yes. Will others not? Probably yes. Carrie?
Yes, exactly. Yeah, no, that's exactly my sentiment as well. It's very interesting because there have certainly been clinical trials that have come out with our existing disease-modifying therapies, specifically our B-cell depleting agents like ocrelizumab, and in being able to determine whether or not someone who is on one of these therapies has any decreased ability to mount an immune response against, common vaccinations that we use, including the Tdap vaccine, which is the tetanus, diphtheria, pertussis vaccine, and the seasonal influenza vaccine. And based on the robustness of these studies, we've been able to change our practice in the MS field to advise our patients who are getting the seasonal influenza vaccine, to try to time that vaccine so that it is within a certain time frame before their next ocrelizumab infusion or rituximab infusion. Some of those guidelines are about 4 to 6 weeks prior to their infusion. So it'll be interesting to see in terms of the immunosuppressant agents that are specifically impacting our memory cells, or memory B cells, and whether or not we'll be able to recommend this vaccination in a different timely fashion, just like our other monoclonal B-cell depleting agents, or whether or not there would have to be some other schedule involved. So I think that's a long way to say that we still need data, and currently it's too soon to be able to answer those questions, specifically because we don't have a vaccine yet. But of course, we want to be forward-thinking and trying to determine how will this impact our population with MS who are on certain immunosuppressant therapies.
Yep, absolutely. Next question. I have primary progressive MS. There are 2 medications due out in the fall. Is it safe to try a brand new DMT at that time?
So at this moment in time, there is only one medication approved for primary progressive MS, and that's ocrelizumab. I can't tell you that I anticipate with any clarity that we'll have before the end of the year another agent for primary progressive MS. We have agents alternatively for secondarily progressive MS, or more particularly active secondarily progressive MS. But my answer here is that for an individual, the question really is would always be the following. I think, Carrie, I heard one of your colleagues from Cleveland, Robert Fox, talking about the use of agents such as ocrelizumab in primary progressive MS, and he said in a telecast, I think that requires a lot of thinking. First of all, it's the only agent for primary progressive MS, and I don't anticipate we'll have another, but the benefit in terms of reduction of progression is real but modest, and in an individual who was worried about the threat of COVID, I think that they sit down with their clinician and say, here's my age, here's my comorbidities, here's what I hope to achieve from this agent. Is this still the appropriate agent for me? What I find is that I was trying to make risk-benefit assessments from the first day I started in medicine till today, but now a new complexity is added, and that is, what will those same judgments now have an additional risk that I need to take into account, and that is COVID-19? The answer is, at least it's worth discussing.
Okay, thank you so much. Next question, what if you work in healthcare with hands-on patients? There were a couple questions about people going back to work or working as an essential employee, and what should they do in terms of precautions?
So I think that at the very least, the CDC precautions in terms of being able to remain socially distant, frequently wash hands with antimicrobial soap and water, use hand sanitizers, and use a mouth or face covering when someone is anticipating that they're going to be in an environment where socially distancing is going to be difficult, are certainly precautions that should continue to be maintained. The advice that I'm usually giving my patients in my practice, for those who are concerned about their work environment, is first speaking with their human resources department, if they have one available, or their employer, about any kinds of work accommodations that can be made if they are concerned about their safety, either because they're working too closely with individuals or they don't get breaks so they can frequently wash their hands. If work accommodations cannot be met and the person with MS continues to be concerned about their potential risk, this might be a time to either speak with their MS healthcare provider, or if there is a social worker who is part of the MS team, in terms of what other options are available. I would say that, again, this really is on an individualized basis in terms of whether or not it's recommended that the person continues to work from home if they're an essential worker, versus, being able to feel confident that they can continue to work in the workplace safely. Some of those factors do include the comorbidities that we have discussed during this presentation. So age is certainly a factor, and other healthcare or health comorbidities such as diabetes, obesity, asthma, and chronic heart and lung disease. And then, of course, who is in the household? Are there, elderly folks in the household? Are there concerns about potentially bringing something into the house, even if the person remains asymptomatic? So there are certainly a lot of factors that have to be taken into place. When it comes to disease-modifying therapies, specifically for the non-immunosuppressant medications, again, that includes glatiramer acetate, interferon beta, natalizumab, teriflunomide, the fumarates, if the lymphocyte counts aren't low, and even the S1P modulators, as long as the lymphocyte counts are within acceptable limits of the MS healthcare provider, I'm not so concerned about those individuals being in the workplace so long as they can continue CDC recommended guidelines. However, in my patient population who are on immunosuppressant therapies and they really are concerned about their health risks, and we try to help support our patients in trying to get work accommodations arranged for them so they can continue working from home and providing for themselves and their families.
Great answer. Thank you for that. Another question, does hot temperature affect the COVID-19 virus?
So there are a lot of things that, again, one of the things I want to keep emphasizing is that we are trying to understand a novel mutation of a virus that's been around clinically for, I guess, probably 4.5 months. And there is speculation that, like influenzas, that there will be some seasonal variation, that we'll see a decrease during hot weather. But we know that this has been able to take hold and spread in cold climates and in hot, humid climates. So I don't think that heat or humidity will be a sufficient answer. May it modify the disease? It's possible. May summertime and people being more spread out modify the disease? It's possible. But right now, I would say don't count on it and presume that this virus will be around and will probably sort of reoccur seasonally for a while till we either have what's called herd immunity, which is when enough of it have it, or until we have a vaccine that will protect some of us from it. Answer, don't count on heat and humidity to drastically change the course, though I hope it may mitigate it a little.
So Peter, if I would be able to insert a question here, just because it does relate to some of the statements Dr. Hendin and I have been making throughout the program. Someone had asked, what are normal lymphocyte counts? Because I know that I have reiterated this quite a bit, at least during the times that I have spoken. So normal lymphocyte counts, there is a specific range that is reported when an individual gets a complete blood count plus auto diff. And this is part of the routine screening and monitoring while folks are on most disease-modifying therapies, not all of them. Not all of them being glutathione or acetate. That normal range sometimes is a little bit different when you compare one particular lab to another lab. Usually speaking, that lower limit of normal for lymphocyte counts is about 1.0, but some labs you'll actually see it going down to about 0.8. So that normal, and for the relevance of MS, we're usually looking at the lower limit of normal, not the upper limit of normal. But the lower limit of normal is usually anywhere between 0.8 to 1.0. Just to answer someone's question as it pertains to some of the comments that I've made.
And Carrie, I think I'd like to insert an answer to a question probably that has, whether or not it's been asked tonight, it is asked all the time, and that is the question of if you do get COVID-19, are there any proven therapies, be that hydroxychloroquine or antiviral agents such as remdesivir or convalescent plasma? I think what everybody needs to know is that these are being investigated and that they should not be taken outside of a scientific protocol. I think there was some initial enthusiasm for hydroxychloroquine, Plaquenil, but there has now been some skepticism as to whether there is benefit or alternatively risk outweighing benefit. I think that there is still some interest, but without positive results, sufficiently positive results on antivirals such as remdesivir. I think that there is still interest in convalescent plasma, but it's still not yet a recommended, scientifically demonstrated study with clear outcomes while we await vaccination. And so the things that we should be doing are the things that we should have done all along. That is, stop smoking, start exercising, get your weight down, control your diabetes, control your hypertension, make sure your health is intact, maintain those things which are part of good health, because that means that you are kind of prehabilitating, making it so, less likely that if you get COVID, that you will be one of the people severely impacted.
Thank you, Dr. Hendin. I appreciate that. And one last combination question from the audience, and then I had a few wrap-up questions myself. So if you do happen to have COVID-19, should you avoid taking ibuprofen, and would any deep breathing exercises help with the lungs?
So I'll answer, if I can, Carrie, on the ibuprofen, although I think we've discussed this together and have the same, and I'll let you take on deep breathing. The answer for the ibuprofen is there was a French concern out of the country, France, that ibuprofen might lead to poorer outcomes. That's not been redemonstrated elsewhere, and the findings were anecdotal. So really right now there is no clear evidence that ibuprofen or the nonsteroidal anti-inflammatory agents are harmful. But if there is concern from the individual, it's easy to take Tylenol instead, acetaminophen. Carrie, what do you think about deep breathing?
So I think that's a great question. There, as far as I know, there certainly aren't any data to show that deep breathing has an impact on transmission of severity of MS. I understand where the question is coming from in terms of improving on lung capacity, and I would not want to venture a guess in terms of whether or not that has any robust improvement in one susceptibility. My gut would say probably not. I think that where it is helpful is for stress management techniques. And Dr. Hendin and myself, and certainly the entire MSAA community, are all very strong believers in long-term physical and mental health, not only for folks with MS, but for the larger general community. And stress management during this time, including deep breathing, guided imagery, mindfulness, hobbies, remaining in touch with loved ones, are all very important strategies to be implementing on a daily basis, while we all, have to deal with the current situation as it is. But I think that's a great question. I would say, based on my own thoughts, probably doesn't have very much to do with COVID-19 susceptibility, but will certainly help with long-term mental health care.
Great. Thank you both for that. And a general question for both of you. Have you made any changes to your MS practice or patient care routines as a result of the COVID-19 pandemic?
I can be fairly brief in that regard, and there are changes. Changes. Number one, I have been used to seeing people face to face for a long career. I'm now doing almost all of my work by telemedicine. When I'm lucky, that is with a good image in front of me of the person I'm seeing, and vice versa. Sometimes it's a telephone alone. I expect that will be modified in some ways in the time ahead. I am trying to medicalize my patients as little as possible, and that means that I really do think twice about sending them in for blood studies and MRIs. I'm still ordering both. I'm still getting both, but I have a thought in front of each one now, so it's not routine, but a question of what potential risk am I exposing them to. In terms of the medications I'm using, I go back to the fact that, again, a Bob Dylan quote, which is, may you have a firm foundation when the winds of changes shift. Well, we have a firm foundation about how we treat MS. We want to start treating early. We want to maintain people on a therapy that doesn't disrupt their quality of life, and that the risk of MS is one which is known, so that I don't stop my medicines or change medicines except by the criteria which I've always used. I do ask the question about risk-benefit ratio more than there's one more risk to add to that question. And then I have been and will be even more paying attention to comorbidities. It's always been a focus, and that is we are not doing our job if we only focus on MS and disease-modifying therapies and we lose track of their diabetes, their hypertension, their heart disease, their smoking, their obesity, their exercise patterns, their family, their mental health, their social welfare. Those things become even more glaringly important in the COVID-19 era, even though they were always important. Carrie?
In trying to remain conscientious of the time since it's a little after 6, I would say that my overall practice is very similar to what Dr. Hendin had just summarized. I have also gone mostly virtual, only bringing patients in where it is either urgent or there really is a necessity for being able to evaluate someone face-to-face. In terms of disease-modifying therapy practice, I'm also a strong believer in early disease-modifying therapy, early highly effective disease-modifying therapy. That certainly hasn't changed. The reason for that, especially when we're thinking about the era that we're in, is that, again, MS is long-term, and MS will continue to be here in the next year, 5 years, 10 years, 20 years down the line. And we really want to be careful about our choices in disease-modifying therapies because from a long-term standpoint, that might have some serious implications in one's level of disability down the road. So we all have to remain conscientious of what we're currently having to deal with, but also paying very close attention to what we already understand about MS. We already know from previous clinical trials and robust studies that early, more highly effective therapy does better. So from that standpoint, that really has not changed very much. In terms of MRIs and lab work, like you, Dr. Hendin, I'm being conscientious of what needs to be done now versus what can maybe wait in a month or two. But I would also say that, you know, folks who are on disease-modifying therapies, they still need to be monitored. So any delays or pushbacks need to be weighed on an individualized basis. And I absolutely agree with you in terms of comorbidity management and making sure that we continue to encourage healthy lifestyle practices.
Great. Thank you both. And just wanted to give both of you an opportunity to provide any remaining closing comments.
My closing comment really is what a pleasure it is to again work with Dr. Hersh and you, Peter, and to further the mission of MSAA in really trying to educate people with MS about what is a concerning issue for everybody in America, but also with unique perspectives on how it is if you have MS or treat MS. So I'm thrilled that there are people, a number of people who have phoned in from across the country to remain educated about this and our commitment to keep on with their education. Thanks.
And I would just add to the entire community, MS and otherwise, please continue to be well and safe and stay strong. We will get through this.
Great. Well, thank you both. Well, we have reached the end of our program tonight, and I want to thank everyone for joining us and for your great questions, and a lot of great questions tonight. And especially thank Dr. Barry Hendin and Dr. Carrie Hersh for educating us about the coronavirus, its impact on MS, and ways for us to stay safe and healthy during this critically important time. I also want to thank our funding partners, Bristol Myers Squibb, EMD Serono, and Genentech for supporting this webinar series. As a reminder, our next webinar on COVID-19 is on Monday, May 11th at 8 p.m. Eastern. You can sign up for updates on this and additional coronavirus information by going to mymsaa.org/coronavirus. Also, as mentioned, tonight's webinar will be archived on our website very soon. And finally, please consider completing a very brief evaluation survey that is coming up next. So on behalf of MSAA, thank you so much again for watching, and please stay safe.